Welcome to Compass Opioid Stewardship in Practice. Each week, our Compass coaches will explore a real-world case, define a clinical goal, and walk through practical strategies to improve care. Whether you're tuning in via video, audio, or reading the summary, this session is built for busy clinicians like you. Enjoy the show. My name is Dr. Don Stater. I'm an emergency and addiction medicine physician and the medical director of the Compass Opioid Stewardship Program. This week's case involves Mary, a 50-year-old patient who presents with long-standing knee pain and Xray proven moderate osteoarthritis. Mary is interested in trialing a steroid knee injection for her osteoarthritis and has trialed other interventions including OTC medications and lidocaine patches without significant relief. As her clinician, you believe that prior to trialing knee injections, that physical therapy, lifestyle changes, and diclofenac cream may be important to trial before progressing to knee injections, given her young age and potential harms of knee injections. Today's microlearning is on the power of patient expectation in defining patient pain relief and how to leverage placebo effect for the benefit of patients. Let's start with some history, namely on the placebo effect. The placebo effect has likely existed as long as humans have tried to heal disease and help one another. Ever since we've had healers dating back to the time of Hippocrates and likely far beyond, healers have done things to patients, and many times patients feel like what has been done to them made them feel better. Whether it was exorcising demons, draining out bad humors, or providing medications, always in medicine we've had placebo. The British physician John Haygarth is the first doctor to describe the power of positive suggestion and belief, the core idea of placebo effect. He came to his conclusions using the example of Perkins rods. What's a Perkins rod, you may ask? Well, in the late 1700s, an American physician, Elijah Perkins, had invented two metal rods, which he claimed were made of special metal alloys that could pull out disease. The rods were extremely popular to the point that even President George Washington owned a pair. But Dr. Haygarth proved that many people had the same positive results of pain and symptom relief, even if the rods were made out of wood or other metals or other materials, not these special alloys as purported. Haygarth thought this demonstrated that the story, the explanation, and the positive suggestion created the effect. The placebo effect in its scientific application was pioneered further by American physician Henry Beecher, who noted the distinct difference in pain management and expectations between soldiers in World War II and civilians he cared for before his deployment. Namely, soldiers often needed far less morphine than those with similar injuries in non-war environments, due to expectations and also context. Soldiers who were in the midst of war and got injured often were sent home and were grateful for not having died like they saw so many of their colleagues, and that really defined the pain story. Recognizing the power of placebo, Dr. Beecher is the developer of the double-blind placebo-controlled trial that recognized the need of medications to prove that they are better than placebo to have actual clinical utility. Since then, the term placebo has sometimes come to be understood by laypersons or clinicians as being fake or ineffective. But I would contend that the biophysiology and psychology of placebo effect is one of the most effective and safe tools in medicine and in pain management. The power of the placebo effect, and also its corollary opposite, the nocebo effect, where negative expectations drive negative outcomes, are well described in an interesting study conducted by Ulrich et al. And is called The Effect of Treatment Expectations on Drug Efficacy, imaging the analgesic benefit of the opioid remifentanil. In the study, healthy volunteers were given infusions of either remifentanil, then subjected to painful stimuli. Before beginning the infusion, the subjects were separated into three arms. In one arm, they were given no counseling or advice on what medication they were getting. In the second arm, they were told they were being given a powerful analgesic. And in the third arm, they were told that they were being given a medication that significantly increased pain sensitivity. What they found was that by providing subjects with positive expectation, that the patient's ability to tolerate pain almost doubled. When given negative expectations, the response to remifentanil was eliminated. And with no explanations or expectations, it fell somewhere between the two as normal standard treatment. It is remarkable that through positive expectation, you can double analgesic effect, and through negative expectation, completely eliminate it. So let's get back to our case. As you discussed with Mary a more conservative approach, you try to talk about the evidence for physical therapy, Voltaren gel, lidocaine patches, and other things like exercise and weight loss. In combination, you emphasize that these medications and strategies have been proven safe and effective, and you encourage the patient to give it an honest 2 to 4 weeks of really trying and leaning into this new strategy for pain relief before considering in-office injections. Following up with the patient in a month, she endorses improved pain and function and is okay with delaying shots until her knee pain or osteoarthritis further worsens. It is a great example of how stated belief of benefit can lead to real-world positive clinical outcomes. But it also requires us as clinicians to really lean into what we're saying and to know the evidence so that we can communicate this to our patients. Let's summarize with some key clinical pearls. 1, the placebo effect does not denote inefficacy. In fact, it has significant benefits and, when applied correctly, little clinical downsides. 2, studies have shown that we can induce placebo or nocebo effects, which can either double the effectiveness of analgesia or completely remove its effectiveness. You want to do the former. We want to induce placebo, not nocebo. 3, clinicians can utilize positive psychology, point out evidence that this will be of benefit to patients, making their clinical care more effective and also more of a partnership. And 4, I often operationalize this by both speaking about positive effect with patients, but then sending them clinical studies or follow-up for them to read and further educate themselves. I hope that this has been beneficial. This show has been brought to you through the generous support of the Centers of Medicare and Medicaid Services. Thanks for joining this week's Compass Opiate Stewardship in Practice. Thank you for being part of the Compass Opiate Stewardship Program, and thank you for all you do caring for your patients. See you next time.